Thank you very much.
Sorry.
Thank you, Mr. Chairman. I'm Oliver Case. I work in Leeds as a urologist. This is part of a consortium of other colleagues who are based around the UK looking at this interesting topic. My conflicts are related to this being an industry-sponsored study. So we know that acute retention is commonly due to enlarged prostates in often older men, and the traditional treatment paradigm for these men will be to have a trial without catheter, and if they fail to avoid following this process, then often invasive BPH surgery is required to get them catheter free. The consequences of long-term catheterization or invasive BPH surgeries do, however, harbour quite significant and suboptimal outcomes for some men, and therefore we wanted to assess and validate, more importantly, the role of minimally invasive treatment in the form of a prostatic urethral lift or a urolift in patients who are in retention, as this was not under the current license for the product. Excuse me. So, Pulsar is the acronym for the prospective study of acute urinary retention patients, and we enrolled 52 men who were aged over 50 with a diagnosis of BPH and had at least one unsuccessful trial without a catheter whilst on an alpha blocker. We performed the urolift implants as per the standard technique, as also described in previous publications, namely the LIFT and BPH6 studies. And our primary assessment was essentially how many patients were passing their trial without catheter on day 3, plus or minus 1 day. And we also collected data, as you can see, for further assessment. For those who've not seen a urolift procedure, this is a fast, effective, minimally invasive treatment using a pre-designed device which will fire a staple implant through the prostate to allow traction of the lateral lobes to create a channel through which men can void more easily. And certainly the data is compelling regarding patients with standalone LUTS symptoms as to improvements and rapid recovery from surgeries. And we wanted to see if we could transpose that across into patients who were catheterized and in retention. So the results. The differences that we were seeing in this patient cohort to the ones more traditionally treated for LUTS is that they were older and the prostates were significantly larger. And this may be a manifest of the disease process, but also the adoption of taking on more challenging prostates, having been doing urolift procedures for 4 or 5 years now. As you can see, the catheterization times are quite considerable, and preceding that, a large number of patients had low urinary tract symptoms for a number of years. We completed the urolift procedures in all men, and the average number of implants inserted was 4.8 plus or minus 1.4. Our primary results and outcomes with that, on the day 3 TWOP, we managed to get nearly 60% of men catheter-free and voiding. We then, if they failed that trial without catheter, we would then bring them back on a weekly basis to try for further voids, and we've managed to get men 80% free of catheters by 3 months. Safety analysis, we were very interested to see the safety profile for the device, bearing in mind men were catheterized and we were dealing with larger prostates, and 42% of men have reported some form of adverse symptom, although the number of more seriously adverse events are actually quite rare and minor and resolved in good timely fashion. So far, 5 men have been retreated, 2 with repeated urolift procedures, 2 with a HOLEP, and 1 with a TURP. 2/3 of men were able to discontinue their alpha blocker as part of the treatment they've undergone, and nearly 90% of men were returned to normal activities within 8.5 days. We also looked at patient satisfaction, and again, as part of the rapid recovery process, we saw that 96.2% of men reported being much or very much better at 6 months, and obviously if you're catheter-free, this highly impacts your satisfaction scores. 88% of men would recommend the procedure at 6 months, and when we looked at the erectile function, there was no change or indeed improvement. These are when we look back and compared the results to BPH6, and actually there's a trend, although non-significant, for these men to be symptomatically better than the comparator, and that's based on the fact that they have catheters in situ, whereas the BPH6 study patients didn't. That leads to better overall satisfaction as far as quality of life is concerned as well. And then when we looked at the incontinence severity index, again, there was no change, and very few men report having any kind of incontinence issues. So, in summary, when you're dealing with men in acute retention, particularly in socially funded healthcare systems, there can be long wait times, leading to delays in treatment and men having to have catheters inserted for considerable periods. We feel that PUL has a safe and quick ability to restore men to normal voiding. The patient experience was superior with rapid return to normal and high rates of patient satisfaction. Symptom outcomes were consistent with our previous findings in other patient groups. Most patients did not have incontinence at baseline or at the 6-month follow-up, and erectile function was preserved. We're also conducting a retrospective review of HOLEP and TURP patients in our institutions over a 2-year period as a sort of control arm to see what happens in those patients. So I'd invite any questions at this point, and thank you for your attention.
Are there any questions? Oh, there are 2.
Hi, Helen Morton from the Freeman in the UK. There was 2 questions. The first was, you'd said 67% discontinued their medications prior to surgery and they remained medication free. Did any patients then discontinue medication following surgery at all?
It's the other way around. So the small proportion that would continue on medication, part of the initial protocol was actually we plan to stop those medications.
Right. Okay. And then the other question I had was, I forgot that.
Janelle Brennan, Australia. So I might have missed it, but did you do a cystoscopy on them to exclude a intravesical median lobe?
Correct. So MedLift hadn't been published by that point, so we kept with exclusion.
So my question for you, having done quite a lot of urolifts and involved in clinical trials, is how many people were excluded? Because certainly in Australia we see a very high rate of intravesical median lobe, and especially those that have high post-void residuals and retention. So I'm interested, did you record that?
Yeah, it's a great question. I would say it's about 30% were excluded because of a middle lobe. Whether they could have been treated, I don't know, but we had a blanket decision to do that.
So very quick last question.
Sorry. So the other question I had was just with regards to the patients who failed their trial thought catheters. Did there appear to be a relation as to how long they'd had the catheter in preoperatively? Did that seem to affect the success?
I mean, we're at a 6-month interim analysis point. The study closes in December, and hopefully we'll get a bit more data on that sort of thing. At the moment, it doesn't seem to correlate with the timings for how long catheter was in. I think it's going to reflect, and we do have a small bit of urodynamic data in these patients as well. It's the older guys, the bigger prostates, who are probably struggling to void first time around.
I've done a couple of those urodynamics myself, actually,
okay.
for you.
So thank you very much. I think we have to continue.
Okay.
I've got a good recommendation. When you publish the data, please use Clavine Dindo system, because I think this is something you need in your publication.
Sure.
Yeah.